afternoon. So, telemedicine, it sounds as though telemental health is a little bit of a newer thing here in Montana, but I'll tell you a little bit about me. I'm originally from Kentucky. I've been in Montana now for about 5 years, and I did telemedicine to rural counties in Kentucky for 10 or more years before I moved here 5 years ago. And when I moved here 5 years ago, one of my asks coming to Providence was to set up our telepsychiatry services. It took a little while to get the system to say, okay, let's go ahead and do this thing. In fact, we kind of went off on our own for a little while, and then now we're all a part of the big Providence system. So I think that everybody who's attended any single session today has already heard about our needs and that are unmet here in Montana. So at any given time, 1 in 20 persons is going to be affected by depression. 1 in 10 will be affected by some other mental health issue at any point in time in their lifespan. Mental health services here in Montana, we've heard about long wait times to get into my office is about 3 months. Telemedicine-wise, though, I have a much shorter wait list. There's a whole bunch of other busy things here on this slide, but so our services that we're developing in Montana right now are pretty close to what I did in Kentucky, which is ambulatory services, and it's just general psychiatry outpatient services. So if somebody comes into the office or the doc says, hey, this person is not being very well managed, let's have them see Dr. Salyers. So we do a full initial evaluation, and then I do several follow-up visits, and hopefully that at that point those patients will be stabilized and can return back to their primary care docs. Not everybody wants to take their patients back though, so that's been a little bit of an issue there. I see patients 4 days a week, not exclusively telemedicine. I have just a little webcam on my computer screen, and so I will see live patients and telepatients and live patients and switch back and forth throughout the day. I have one day that's fully devoted to a particular site. The site reviews, is that what you do, Jody? Okay, thank you. So Jody Haynes is our telepsych. She does our whole telemedicine for the Western Providence area, so she covers a whole lot of other things besides just psychiatry. So she helps she goes out to each and every site. She and her people will go out there and develop workflows, and those workflows are developed for each individual site. So not everything works in a very standardized fashion for each and every facility. We have one facility that still is on paper records, so they don't do any of their own scheduling. They don't send me a lot of records. Yeah, it gets a little iffy with that particular site. And they have some extremely ill patients out there too. You know, again, reminding us that these are very rural areas with very limited mental health access. These patients are a lot more ill than what I think that sometimes these things are actually designed for. Oh, so there's my wait times again, a lot shorter than it is to get people into my outpatient practice. These are the sites that we're in presently. The green star is us in Missoula, and I see patients in Plains, Polson, Superior, Florence, Deer Lodge, Anaconda. Isn't online yet, but they're coming up in the next couple of weeks, I think. And Dillon, I see a lot of people in Dillon. And Plains and Superior are coming up pretty quickly too. So this is the ideal, is that this would be a patient complaint that is easily managed in an outpatient setting. I'll tell you off the top of my head, I've had to hospitalize a great number of my patients on their initial assessments. I've sent patients to inpatient addiction services. I've sent patients to our inpatient psychiatric services. And I have a lot of patients that I manage that, quite frankly, could benefit from some more intensive services than what's available to them. We haven't gotten to that place where we're just, kind of basically covering bases with that patient who has the overall chronic health conditions like diabetes or hypertension that we want to just be helping those people manage. Right now, what I'm managing is really pretty severe psychiatric illness, but we intend to get to that place with the behavioral health interventions. Oh, and there's our little successes. I've had a couple of people who have really enjoyed seeing me. Do we have, Jody, I apologize. I am so sorry, folks, but so system-wide, we have acute telepsychiatry services as well. So Providence is in Alaska, Washington, California, Texas, and Western Montana. So system-wide, the services that they're developing for telepsychiatry are actually more acute. So consultative services to ICU, delirium, inpatient, medically admitted patients, or the emergency rooms. So I think that they've had a few other successes as well. Questions?
That's your overview of your good services. Yeah.
Well, I guess, are you looking to expand? I mean, because I think everybody in this room would be happy to
provide you with patients.
Yeah. I mean, I guess, what are the options of expanding these?
So, do you want, I'm happy to jump in.
You can jump in and I can share a little bit as well. We do not have child and adolescent services, which is a big gap in our services, and we do want to build that. I had a friend in Kentucky who was going to try to work with us, but it hasn't really panned out for him to do some telepsych services from Kentucky to here. And we don't actually have anybody that's doing it. Quite frankly, there isn't anybody else in my practice who's particularly interested in doing it.
I mean, not East.
Oh, Jody can speak to that.
So we do have a couple ideas brewing, but we also realize that, like Dr. Sellers mentioned, the pediatric piece is something that we just don't do at this point in time, and we'd love to be able to actually offer that service as well, so the whole age range. Dr. Sellers is actually great, and she can go down to about 10 years of age or 11, I think is the youngest she would go, depending on if it truly would be a good fit or not. So anything less than that, we still are seeing a need for that. So that's number one. Number two, we're also seeing in terms of wraparound services and the LCSW perspective. So we have a lot of new practices that are coming on board with enhanced primary care settings that not only need the behavioral health integration, but want it. And my gosh, as a state of Montana, we need it. So definitely we're trying to figure out what we can do to help scale to size. The number one thing I think internally for us is to make sure our quality stays top of mind. And so as you can see with our quality so far, it's pretty good. And so we want to make sure we're addressing our scalability in an appropriate manner, but absolutely it's something that's on our radar. And we've actually had quite a few calls from the eastern side of the state, central part of the state, even out of state, far west as the Olympic Peninsula in Washington for these services. So it's on our radar. I know Dr. Sellers wants to move to Billings and just see tele patients there.
That's my goal.
Regular check-in meetings there with her. So, answer to your question.
What are you using? I mean, what are your requirements, like on bandwidth side or for the telemedicine?
Right. So it depends on the site visit, and we'll talk about those technical, and I've got people I can lean on to answer that more specifically. Right now, that's something that is determined at the site level to make sure they can hold enough bandwidth exactly for that. We use VidYO right now as our software. We're actually moving away from that, we think, into some more robust and proactive modeling systems, not only for the technology piece for telehealth, but also to help manage the patient panels. in those primary care practices in addition to Dr. Salyer. So again, it's not just dumping the patient on her, but it's part of this teamwork so we can actually see what makes sense. And that's a different piece too. So we can kind of layer both just the technological side with the telemedicine piece to implement it, and then also the additional layers if that would be of interest.
Yeah, I mean, from my side, I'm a lib services, like ISP provider, and we're really trying to see what are the requirements that you need, especially in more rural areas, so that we can fit that need and make sure that we have the bandwidth there for telemedicine.
Right, and I think so that's going to lean on IT infrastructure there locally, but also our new solution is cloud-based as well.
Okay.
So that offers a lot more flexibility and just where telemedicine is going. I mean, it's so new, but it almost changes daily already. And so just making sure we can establish and keep that connectivity over the long term. But I am not the best person to ask IT questions about, so I hope that that's enough. We can talk later, but yeah, okay. Thank you.
We have some other folks on our panel that may have some information too as far as the actual details of the process as we go forward. Did you have a question specific for
Yes.
Dr. Salyer?
Quick question, one for you. Is your practice all covered by psychiatrists, or do you use any other therapists or counselors?
As far as our telepsychiatry is concerned, I'm it. But we do anticipate moving forward with social workers, and I do have a PA in my practice. We do need to build in a little bit of extra depth. I had a sick day and had to reschedule a full day of patients, and so we do want to get some other folks involved just to at least help back me up.
And then a question, you said that you go and visit the facilities. So does the patient move or go to the facility and have?
Yes.
Be
Yeah,
able to do
this is not that
Is it like
direct to
What
consumer.
kind of facility is it?
So mostly rural health clinics
Okay.
is where they all go. It's a business-to-business model, so the patient will actually stay in their community, not their home.
Right.
They'll drive to the clinic setting and then be with Dr. Salyers in his clinic.
So psychiatry is a little bit interesting. When I was in Kentucky and did this, so just to give you a little bit of perspective, for the counties that I served in Kentucky, they would have to drive maybe 2 hours, or even just 30 minutes, as close as 30 minutes, because we have, the counties in Kentucky are 120. It's a much smaller state than here. The counties were developed so that the judges could travel from one county to the next in a day's horse ride. Okay, so our counties are a lot closer. So there, my patients would come to me and we'd have a face-to-face initial psychiatric eval, and then the rest of the time those would be follow-up evaluations. But here it's just impractical to do that. The patients really, I don't expect them to come if they're going to have to drive 3 or 4 hours. So we do them initial, and the patients here, and I'd have to say a lot of the docs here, we're a little skittish about the whole idea of this telemedicine thing. And having done it for such a long time, I was kind of, why? Why are we so worried about the technology? But honestly, once you and a patient sit down and do it, the technology just falls away. And I think we heard in the last session that I was in, this stuff is really great for the younger generation. I'm in that 50-plus category and ready to be looking toward retirement. But my friends who are child and adolescent psychiatrists who do this with kids, the kids really love the technology.
Thank you, Dr.
Anything else?
Salyer. If you would like to just have a
One of the things that I just wanted to share with you a little bit before I get started on my presentation is that the Northwest Telehealth Resource Center, which is one of 12 resource centers throughout the United States, serves the state of Montana, Idaho, I always have to count them on my fingers, Washington, Idaho, Montana, Wyoming, Utah, and Oregon. And a couple of years ago, they did a very extensive video program on how to do telemental health. and it's very well done. We used a psychologist, to do the presentations. And so all you have to do is go on nrtrc.org, pretty easy. And it's a very well done program on the things that you need to look at when you're doing telemental health, the kind of bandwidth you need, how to present the patient, how to present the provider, etc. So I advise you all to go on their website and take a look at that. nrtrc.org. Yeah. And it's video snippets because we learned people don't want to read anymore. They want to see. And so we did a really great program. So please take a look at that. So just a disclaimer, this picture here my husband took out of our kitchen window. So pretty awesome, huh? We live on the Yellowstone. Enjoy living there. So I have the privilege of being able to work with Central Montana Medical Center, working with them on a collaborative care model that they have established in their organization about a year ago. So one of the things, and I think some of you in the room may even be partners of the North Central Montana Healthcare Alliance. There are 11 hospitals, and that's the region, critical access hospitals who are members of the North Central Montana Hospital or Healthcare Association. I think Central Montana Medical Center is one of them. About a year ago, they were talking about what is one of their greatest needs. And as always, mental health is right there at the top, right? So how can we do a better job of providing mental health services to our patients in our small communities when our doctor just told us, waiting time can be up to 3 months? And so there was a grant that was offered through HRSA that offered to so this group decided that they wanted to apply for it. And so they said, well, what we would really like to do is we would like to implement mental health services in our primary care settings. And so that was what we said, all right, then we'll take a look at figuring out how to do that. We were familiar with the concept. We knew that a lot of organizations had started doing it already. And so we looked at developing a proposal for that, which we were funded. So fortunately, I've been around since the beginning of time. And so I knew people who were doing, this collaborative care model. And so I got a hold of a friend of mine who was at the University of Washington. And I asked her, what can we do to build out this program? And so she connected us with the Ames Center at the University of Washington. And they have built a best practices model on collaborative care, on implementing behavioral health into the primary care setting. And so we worked with them in developing our model, and they have been very instrumental in helping us develop the program that we got funded. We just got funded in July, and so we are still in the implementation phases of it. I'd love to come back a year from now and tell you, concept versus reality, right? But at least we're building a model that we believe, and we know will work for us in rural Montana. Now, so the core principles of the collaborative care model is that it's a patient-centered care, right? So we're working in the primary care setting. And what ends up happening a lot of times, and I know that I'm speaking to the choir here, is that a patient comes into the physician, and the physician identifies that there are additional needs that they have beyond the basic physical care. But they have 15 minutes maybe that they have to be able to spend time with that patient. And so it's really difficult for that provider then to really take on that role of that. What do we do about the anxiety my patient is feeling? What do we do about med management? What do we do about trauma? All of these things that are going on in this patient's life. So, you know, some of the buzzwords, right, that we're all dealing with right now, population-based care, you know, we're taking a look at the whole patient now. We're not just looking at episodic care. What are we doing treating to the target? And then we're also, there's so much data out there anymore that we really can take a look at evidence-based care. And the Project ECHO, I think, is really along that evidence-based care. We're doing a lot anymore with education, with providing case studies, working with providers all over anymore, because we have that capacity now with the technology, that it doesn't really matter where you're at anymore. You can access the patient, you can access the providers, you can access the education. You just need, sometimes we just need the help to get there. And then with the influx of the Accountable Care Act, we've seen a lot more movement towards using telemedicine, creating care management models, that whole world of we're treating the whole patient, we're not just treating the episode. So what we did is we took an urban model and we're turning it into a rural program using telemedicine. And so we have the care team in the local site is the provider. The provider identifies the patient needs additional care. He refers the patient to the care manager, the local care manager, who does an initial assessment with that patient. If they determine that patient needs care beyond just maybe social aspects, you know, maybe they have stuff going on in their life right now where they don't have a stable home life, or they don't have food, you know, the kind of the basic needs, that kind of stuff can be managed in the local community, right? So if they can identify, a workshop I was at yesterday said that 95% of the mental health issues can be managed in the primary care if it's managed right. And I think he was absolutely right. I think a lot of times when somebody comes in and they have anxiety, that anxiety might be centered around a specific event. So if we can address those specific events, we might be able to take care of that. But if we can't, then that's when these patients are going to be referred to the LCSW that we have, that's in the center of that photo that you have there. And then the LCSW will do a risk assessment, and then they will work with that coordinator in the home community. They will also work with the primary care provider, and then they will refer that patient on to psychiatric services if needed. And so that's the model that we've created. We really want to keep as much of the care in the home community as possible. But we also recognize that in a rural community, that is the provider is the physician. He's also doing the ER. He's also managing a number of things. We want to be flexible enough with our program to be able to identify what part of that care needs to be transitioned off to the paid staff outside of their community, and how much of that care can be retained in their home community as well. Excuse me. Now, you know, we have some money to help pay for the care manager, but we also know that many times that care manager is just going to take on another job on top of the jobs that they already have. We're fortunate enough that for the last year, we've been doing a care management program in Lewistown, so we have a pretty good sense of what kind of patients we're going to start getting referred to our program. And we've done a lot of work building that relationship with our physicians. We've done a lot of work building that relationships with our patients. And I can tell you the kind of people that our care managers are working with are people who have some very basic needs. that for some reason in their growth process, they just have not had those needs met for whatever the reason it might be. We have a mother in our program right now that wants to do a really good job raising her baby, has no skills on how to take care of a child, on how to cook for the child, on how to take care of the child. So our staff are working with her on a regular basis, and I would guess our care management team probably has 10 hours a month working with that patient. There's no way a physician can take that kind of time to work with their patients, but yet they care enough about those patients that they're the ones that come into our office and say, I need you to see this person and I need you to see this person today. And so we really believe this care coordination program is going to help to address some of those needs that those CEOs of those hospitals have told us that they desperately need. So, communication is the key, right? Communication back and forth, communication with the provider to the, I'm sure that was probably me, right? I was probably that patient that got dumped on the floor. But so it's real important that we have good communication on all fronts of the program. And so we are really working hard at that. We're very fortunate, once again, that we have a very open and willing medical director in our care management team in Lewistown who is very, she talks with us on a weekly basis. She's very willing to carry the message back to the providers. She's very willing to share with us what the providers need. We're very fortunate that we have that open communication in our team in Lewistown. We also recognize we really need to have that kind of open communication throughout those 8 communities, right, that are going to be on this telehealth model with us. So part of it is people aren't used to using video conferencing. So one of the very first things we're going to do is we're going to buy Logitech cameras, we're going to buy Jabra speakers, we're going to go out, we're going to put them on everybody's computers, and we're going to have weekly meetings with them where they have to come on to that meeting via video because they've got to get used to it. It's amazing to me how many people say, oh, no, I don't, I'll just call in. I'm like, nope, you're not going to call in. You're going to be on the video. I want you to be on the video with us. And anymore, I hardly ever have any calls where I'm not on a video call. I mean, it's just the way my world is. I'm probably on a video call 4 to 5 hours a day. So the components of the collaborative care model, the cool thing about video, by the way, if you don't want to, if you want to like eat something, you can always turn your video off. And then there's a nice picture of you, in there too. So there's ways you can work. Or if somebody's saying is really irritating you, you just turn your video off, right? And then somebody else on it's texting you going, all right, Doris, what's going on? So, and I'm sorry I'm digressing, but I was in a video call and a spider came crawling down my wall, and I just kind of freaked out, and I was jumping around, and one of the gals on call, she goes, what is going on? She texts me, what is going on? And I said, oh, I'm sorry, a spider just crawled down my wall. So, you tend to forget that everybody can see what you're doing, so we do have to be a little careful. We're very good at muting our audio, right, when we're not the one speaking, which is a good thing because I probably screamed as well. So anyway, so the components of the collaborative care model is that there's a real strong relationship between the care coordination and the care management team, right? There's a real strong correlation between the provider and the care management team, and then that relationship back to the provider so that the provider knows that we've got the information in the patient's medical record so that the provider can read whatever you have done with that patient. That's really important. important, that there's proactive monitoring and treatment to target. Excuse me, every patient we serve, we have a treatment plan for that patient. Every time we see that patient, that treatment plan is updated. And that is put back into the medical record. So the provider always knows at a glance what's going on with their patient. And then there's regular caseload review. Our staff, right now at least, we're not so overwhelmed, they can staff their patients. And they do that on a weekly basis. So the other thing that's really important for a model like this to work is to ensure that we have reimbursement, right? That we have a sustainability plan. We were talking earlier, Thelma and I were talking with the CEO of one of the critical access hospitals, and he said, I love to be involved in these grant programs, and I really enjoy doing the work that we do with them. He said, but inevitably at the end of the grant, the program ends. We don't want that to happen here. We want to create a sustainability model that works so that that provider and that critical access hospital, that clinic, is getting reimbursed for the services that they're providing. So the ROI for collaborative care is $606.50 for each dollar spent, according to a Wall Street Journal article. So, we all know that at the beginning of this year, CMS started reimbursing for collaborative care activities. And so these are the 3 G codes that they reimburse for. And so the first 70 minutes is $142. The first 60 minutes for any subsequent meeting after that is $126. And then for any additional 30 minutes is $66. And so that is what we're building into this program. So part of this program is teaching the billing people in the rural communities how they can bill for that care management, because that is so important as well. So each G code bundles payment to the primary care for the work of the collaborative care team. And this is new, and so a lot of people aren't used to it, and we recognize that. So we recognize that we're going to have to do a lot of education with our partners to ensure that they are familiar with how much time they need to be providing care to these patients per month in order to receive their reimbursement. Yes, sir.
How does the income get distributed? Go to one party and they distribute it?
No, because the patient is retained in the rural community, right? Oh, I don't know the answer to that question. I'll find out though. So the reimbursement part of it is part of what we're working with the AIMS people, so that they can train us how to do the proper reimbursement strategies for this program. But it's real important because when we talk with our CEOs in our critical access hospitals that we're working with, they need to know how this is going to work for them. How are they going to get reimbursed for the services that they're providing?
One follow-up. Does that work for rural health clinics?
Some of the G code reimbursements do not work for rural health clinics.
But I've heard they're actually going to be.
Are they?
I don't know the timing on it, but I think rural health clinics as well as FQHCs, from what I've heard, they will have the ability also to be able to get these codes.
I wish our
I just don't know the
Medicaid gal was
timing.
in here. I wish our Medicaid gal was still in here. Yeah, that's been kind of a bugaboo, and then the other thing too is if you're CPC plus, you're already receiving the bundled care, right? So then you can't bill for these G codes. But some providers will allow you to bill for the G codes in addition to your CPC plus bundle. So, the thing is never just assume, always ask. So that's my presentation. So Yes.
Doris, what kind of workforce needs might need to be beefed up? You had said there were care coordinators already in place, so will any others need to be hired, or social work, or what kind of workforce might need to be expanded?
Right now, we, each one of the sites in the program will have a local care coordinator. And we'll do intensive training for them on the collaborative care model. And then we'll do the training for the primary care providers as well.
Will that be an RN?
You know, we believe they will probably be RNs because they will probably be the physician's nurse. The collaborative care model doesn't require them to be RNs, but there are certain things an RN can do that they get reimbursed for, like the risk assessment that an LPM or a CNA or an MA would not. And so that's part of what we're working with our partners on, is who is it that you're going to hire to or assign to take on this role. And then we have an LCSW that we just hired in Lewistown, so we're going to funnel the LCSW services for the grant through him. And then we're working with the benefits psychiatric department for psych management, meds management, that kind of stuff. So because benefits is a member of the NMHA group. And so, you know, like I said, we're just getting started with it. We're going to stand up 4 sites first, kind of work through the bugs on those 4 sites, and then we'll stand up the other 4. Yes.
The care coordinator, is their role solely these potential mental health patients, or would they also be, with, say, their physician, if it's a nurse, a physician that they're working with, would they be also doing other care coordinator tasks, like following up on if a med's been changed or that kind of thing, or is it solely just mental health patients?
You know, we're dealing with rural Montana, right?
Right.
It's going to be everything.
Okay.
Yeah, I mean, the model that Ames has is just behavior health, but reality is, you know, especially when you look at 95% of the needs could be managed in the home community, we're talking about basic care management, right? Yeah. Any other questions? Thank you.
I don't have slides. Actually, I'm pinch hitting. At 2 o'clock yesterday, I found out that one of our presenters is ill. And so I'll talk about telehealth anytime and anywhere. And many of us here are members of the Montana Telehealth Alliance. We're the sponsors of this presentation, the panel, and the one previous. And it's a great organization, and promoting telehealth is part of our mission. And so, you know, I'm more than happy to step up and promote telehealth. I'll be looking at my notes quite a bit. I'm a technical person. My day job is I'm a telehealth network administrator. And lots of technical people, when you watch them speak, all of a sudden you see them just stop, and like there's nothing there. You wonder, is there going to be some more words? And last month it happened to me. I was talking to the Montana Telecommunications Association, and after I was done, a name for it happened. It's buffer overrun. You know, in a CPU, it can take so much information, and then it fills up and chokes, and you have a buffer overrun. And if it happens now, you'll know it when it happens, and I'll just go to my notes and try to flush the buffer and then restart. But first thing I want to mention, because you hear the term a lot, and when I talk to people, I try to clear it up: telehealth or telemedicine. What's the difference? Really, it's interchangeable, and if you use it, no one's going to be confused. But telehealth are those things that are health encompassing, community health, education, before you need a doctor, dietary education so you don't end up a type 2 diabetic, things that create and promote community health or your health. Telemedicine is what we like to think is when clinical services are being delivered. And If the terms get used interchangeably, there's no harm in that, but the American Telemedicine Association has kind of divided it that way. So we are the Montana Telehealth Alliance, but we are a telehealth and a telemedicine promoting organization. And if that helps any or makes it more confusing, I don't know, but it's a piece of trivia you might want to know and take away from today. My network in Great Falls began delivering telehealth in 1995, and I say telehealth because we didn't start doing telemedicine until 2001. And those first encounters were mental health encounters where pediatric patients would come and sit in front of a $50,000 to $80,000 codec that was as big as a Chevette, and see providers at Billings Clinic on the EMTN telehealth network. At that time, I think they were the only pediatric providers in the state. That's where telemedicine began for us. Almost about the same time, we also started doing some burn consults with the University of Utah at the Burn Center. But it really began with mental health because it's probably one of the most ideal services you can deliver over telemedicine technologies, because what you need is clear video, clear audio, a good network signal. The other tools we've since brought in, telestethoscopes, teleotoscopes, extra exam cameras, they're helpful in other areas, but you don't necessarily need them for a telebehavioral health encounter. What you need is a good computer or a good piece of equipment to make the connection. I'll get to computers here in a minute.
And the clinician.
Oh, yes, and the clinician. That's what you techie standing there. You need everything. Oh, yeah, people. You've got to have people. You need, you need a patient on one end in need of that assistance, and you need a provider. And actually, that's really critical because honestly, and I'm saying this all the time, we've built such a tremendous physical network of equipment in Montana. I mean, 2001, that's 16 years ago. We should be seeing thousands and thousands of patients all the time, and we're not. And it's because we don't have the people. We don't have the providers. We've had equipment for a long time. So let me flush that buffer and then move on. My network made a huge step forward about 2 years ago. We had a provider, a nurse practitioner, mental health nurse practitioner, who agreed to start seeing patients in one of the Highline communities, based in the Highline. I also like to use this as an example that expertise doesn't necessarily have to be at a hub, a network hub, a tertiary center. Sometimes it's existing at a rural or a clinical access hospital. You take your expertise where you can find it, and then you deliver it to wherever it can help people. And that's an example we had there. Our provider was at a rural hospital, and she could see patients. She had capacity to see them at a critical access hospital. But because of the method that they used, there was a medication agreement, a contract that they had drawn up at the beginning of Med Management was part of these interactions. They needed to look at that document each time they got together. So we needed to do this on a PC. And we're a Polycom-based hardware network, but we can put software on a PC, and that's the first time we started doing that, so that she could turn around and show the patient at the distance, well, here are the things we agreed to, so you remember what we're talking about. And it worked very well. And not long after that, we were able to add a second community and worked well there. It continues to work now, but that's where it stopped because her capacity filled up. And, but it showed that PCs are viable in that application. Move ahead a few years, and now we have a provider, a psychiatrist who does on-call coverage for us, and that person's been supplied because it works best in his practice with an iPad and a hotspot. And that enables him to dial into a contracted video room is what we'd call it. It's on a secure connection, and then we connect from our network to that. It's a Polycom provided service by a Montana vendor, VisionNet. And Again, it's simplified that process away from the $50,000 device in 1995 or the $8,000 to $13,000 carts that we're still using. Great pieces of technology and pieces that we need for other things that we do, telecardiology, teleoncology, where we hook other devices up, not necessarily needed to get the provider, the human aspect connected to the patient. So brings me to the point where we are today, where I've come from. I came into this at 2004, but basically inherited most of that equipment. My job was to convert us to IP technology, but still expensive equipment. Now we can do this with PCs. You can basically set up behavioral health care with a PC. You mentioned the Jabra speaker. I happen to have one along.
They're awesome.
A Jabra speaker. I think it's almost required equipment. A PC with a webcam and this speaker, which it's a microphone and a speaker and does voice cancellation. You get really good quality sound with that. So a PC, a laptop with a camera with this, an internet connection, and then some kind of a secure way to make a connection to a provider that you need to find. That's the one thing I can't help you find, the human person, the human end of this, but I'm here to tell you about probably the most economical ways now to be able to get to them. The other thing I want to stress is when you find this connection, make sure you have a BAA, a Business Associates Agreement, a HIPAA BAA, and I'm going to read something that I found on the internet today, but under the U.S. Health Insurance Portability and Accountability Act of 1996, a HIPAA Business Associate Agreement, BAA, is a contract between a HIPAA-covered entity and a HIPAA Business Associate, BA. The contract provides professional health information, PHI, in accordance with the HIPAA guidelines. It makes your interactions, your connections secure, and when the surveyors come and ask, okay, you're doing telehealth, you're making connections, are they encrypted? That's your proof that they're a secure and encrypted call. And so this is a joke I have to use again, but it's not a coincidence that BAA rhymes with CYA, and that's what it does. This is a 410, I think. Yeah, we have.
Amazon for under $100.
$69.89 at Walmart.
Where's the UC?
Now, I'm going to get on into the weeds again. You can pull me back. I get on these tangents. But going back to the provider that we had that was seeing people in 2 Highline communities and then had to stop. It worked so well. We got news this summer that another nurse practitioner was starting practice in another Highline community, and I and our clinical nurse coordinator promptly made a meeting with the CEO of the hospital and got up there to make a pitch to see if there's any capacity, or basically to say, if you have capacity, we have a method for them to be able to see patients. And the person hadn't yet started. They were in town, but they hadn't started, and we were basically told to, back off, don't smother her. Understandable, and they said, we've gotten a call from a community across the state that heard that this person was starting and wondered if they could get the same thing, which I think really illustrates the desperate need for care that's out there. But I also think that it also illustrates the enthusiasm we have that we can be part of that solution when the provider base can be found. Now, the last thing I want to mention is a method, and Richard from Insight is here. I visited with him earlier, and they provide a service that brings providers to hospitals, and I errantly referred to it as I heard it. I said, oh, you're locums over televideo, and he corrected me, and it's no, he said, we've got people who've been in relationships for years. So think of it as a telepsychiatry recruiting service but the person never actually lives in your community. Televideo is the way they do their practice for as long as they do the practice. And I'll give Richard a minute to kind of expand on that.
Sure, we have 250 prescribers who we employ full-time within our organization. We probably have about 35 Montana licensed psychiatrists and nurse practitioners who are being used in some of the larger organizations here. And that's right, we have long-term relationships with the partners that we have throughout Montana, and work across the entire continuum of care. So we're in ED settings, we're in inpatient settings, we're in schools, we're in lots of outpatient community programs throughout Montana, throughout the nation. And in fact, we're in 27 different states. In fact, we have a booth right here. So we've been providing services into Montana for many, many years. And the company is 19 years old.
And I thought interesting, when I started asking about technology, because that's where I always go, you'd mentioned, well, we're technology agnostic. The connection, they're not a technology company, so the technology is what you're using, and they have a tech department that'll work with you. And I had mentioned Zoom, and not a commercial for them. We're not a subscriber. We're interested in Zoom. I know some networks that are using it as an augment to what we already have, because they can connect to video is another one that can connect to our existing. We have a pretty extensive installed base of Polycom equipment. And I'm not sure that that'll be the solution over the long term, but it's good for quite a few more years, and it produces some real quality images because it was expensive equipment. The high-def cameras are excellent, but we need to be able to connect them to the PC on the other end, and now there are intermediary steps. And so the technology shouldn't get in the way, and I like the answer that we're technology agnostic. It's whatever you're using, we'll figure out a way to make the connection. And I guess if there's any takeaway for developing mental health services going forward, it's to look for those kinds of technologies that can connect to other ways. People bring up Skype and FaceTime a lot. They don't interconnect with those existing legacy technologies, and I don't think you can get a BAA from them at this time. We find ways to use them for things like job interviews and things, because people are out there and you can get to them on their smartphone in a coffee shop with Wi-Fi to do a job interview, but that just won't work for this.
Any questions?
I have one actually. So if you're an originating site and patients, in this case at Kaw Hospital, and to get the capacity you need, you've got maybe 4 different providers who provide the service throughout the state or the country or whatever. And they use 2 or 3 different tech packages, just out of their own preference. Do we have to purchase each one? Or?
That's a good question, and I don't have a pat answer. My pat answer would be to try and convince them to swing over to something you've settled on. That's not necessarily going to work. And I know in the case of our telestroke coverage, basically you need to conform to what they're using on their end. It isn't, this is what the vendor uses, you have to figure it out. And that's one thing that I know all organizations are trying to get away from, is having to support 4 different platforms, especially when they're expensive platforms. I know in the case of something like Zoom or video, because they'll support H323 and SIP calling, that from that one platform you can be able to get to several. But if they're using, like the InTouch robots, they'll only support H323 in one direction. They're really designed to call their own base of equipment. So there's not an easy answer.
And don't you think, Gene, because everything's getting cloud-based, there's less of an issue? It's kind of like, if I call you from my phone and I have an iPhone, you have an Android. Doesn't matter, right? So I think with cloud-based, it's becoming more.
Better than it was, but there's still some counters. And in some organizations, getting through a firewall still isn't as simple as it should be.
Yeah, we're covering 400 different facilities, 450 or so different facilities across the country, and everybody has a different technology. But using both cloud-based technologies as well as having access to a number of different endpoint solutions, we're able to offer our psychiatrists, who are also all over the country, the ability to log into anybody's site. So that in that way, we can focus more on the fit of the prescriber to the facility and ignore the technology to some level.
Yeah, I work at Shodare. We have a genetics program, and our geneticists in the past have always loaded up the car with all their stuff, and they get a genetic counselor and possibly a nutritionist, and they all take off for a clinic in Billings or Kalispell, and so here's these very rare and expensive resources on the road for 3 to 5 hours. So we started using, it's called VC, I don't know if you heard of that, but we use VC.
Yeah.
It's like
SEE.
Yeah. It's a HIPAA compliant Skype type thing, and it's working really well because they actually, the patient or client is actually like at home on their phone doing the consult with the genetic counselor or the geneticist.
No. Our geneticist sits at her PC, and it's running a Polycom client, but she's only seeing patients at another, inside a facility, haven't yet going into the home.
Because of the inconvenience, I guess, to the patient and also the cost. So we just started this a few months ago, and we don't do it for everything. We still do a lot of on-site clinics, but it's working great.
Are you running into any reimbursement obstacles going to the home?
No, we haven't. No, it's just that I think
That's
it's
good to hear.
The modifier for a telehealth or telemedicine visit.
Reimbursement not being the area I'm deepest versed in, but I always step back when people ask about going into the home because I'm uncertain as to how we'll get paid for that.
Yeah, and even beyond that, it's amazing to us. It's the younger generation, very young generation. They are okay with even just texting, which I don't know how that's ever going to be reimbursed. I was just on the one thing about disruptive technology. I mean, we work with kids, behavioral health and kids at Shodare as well, and there's this new organization that's all run, I think, by volunteers, but the kids can just text a number and they can start texting with a therapist or a psychiatrist, and it's like, it's free, and they're having amazing results with these kids, and they never see face to face. And I don't know the generation. I got to see that person. We got to be sitting down. We got to develop a relationship. That kind of stuff. If I'm going to share with you issues in my life, these kids have been talked down from suicide. There's amazing stories, and thousands of users now use that simple text.
I'm of the generation, my texts still look like letters. Salutation, semicolon. And I'm resistant to going to text speak because, I don't know, I feel like...
It will just be interesting as the millennials and others, Gen X,
it's their world.
Get to an age where they would need to use more services, how they'll demand more real-time, very convenient ways to...
I think I can speak for the majority of the members of the MTA. We all feel as some providers retire and new people coming out of medical school, getting them to adopt these technologies is going to be simpler because, and actually, I'm getting in the weeds here, but I mean, it goes the other direction. You can go into an ER where an ER doctor may be pretty quick to want to just send me that picture in FaceTime. Let me see that injury in FaceTime. It's like, no, you can't do that, you know, but they don't care because they use FaceTime for everything. And so that's like too much of a good thing. But.
My kids text me to pass the milk. Taking my phone to breakfast.
Well, that's the thing. You're right. That generation doesn't even want to see a person. They want to just be able to text. It's really inconvenient and socially awkward to actually have to talk to a person. So go in and see a doctor. That's no.
Is texting any play any role with the insights practices?
You can have follow-up care via texting, absolutely. And we also have a division called Empathy, which is a at-home model. We don't employ it here in Montana, but through Empathy, we're seeing, last year we saw about 20,000 assessments. And Empathy is the behavioral health service provider behind Optum and Beacon and several other large insurance companies. And they've gone that way to use Insight to provide services directly to homes. And interestingly enough, we're now applying it to help hospitals to manage the ongoing care once a patient is released, to be able to get ongoing care in some scenarios, in some states, if they're in very rural settings. So that does work very well.
Any other questions and interactions with our panelists? Last comments, Jean? Do you have any last jokes for us?
No, I burned them all up. Yeah. Actually, yeah, the one thing I thought as I was preparing these comments is that I'm, a network administrator for an old-style network. We have a hub, we have sites, and so it would seem here that I'm describing a way to make us obsolete. And I don't think that's the case at all. I think this is a way to extend the care model, but also from the, especially the perspective of critical access hospitals in need of services, wherever you can get them, the technology is affordable now. Zoom, their price is $200 if you don't need to connect to legacy systems, and that gives you 10 connections, which is probably
$9.99 a month.
Right. Yep. So it's affordable to be, if you can find that capacity. Don't be daunted that, well, we don't have a network. Get it any way you can.
You just, when we talk about platforms, the Telehealth Technology Assessment Center is doing an assessment of the platforms right now. It'll be on our website within the next couple of months. There are over 50 platforms now, cloud-based, and so instead of doing an assessment of each one of them, what we're going to do is a commonality. These, this is common in all of them. These are some of the stuff that are different in other ones because, the minute it goes up on the website, it's going to be obsolete, right? So what we're going to do is give you the tools so that you can assess those platforms when you look to do telehealth.
I don't think Zoom will sign the BAA for $9.95 a month. No. $200 a month to give you the BAA.
But I'm saying for consumers.
Yes, absolutely. Yep, and some of them have free options that scale back on the.
We do it for interviews too.
You bet.